PJ Wormald is going to talk to us, and I don't want to dilute his presentation much as I've been asked to. So, PJ, you're going to talk about improving wound healing and surgical outcomes in rhinology. The floor is yours.
Yeah, thank you, guys. Not just rhinology. I'm going to talk all about other aspects of surgery as well. So, yeah, so thank you, and welcome to everyone who's with us today. So, you know, we are based at the QEH and the Basil Hetzel Institute, and you know, it's really wonderful that we do have that facility available to us. We do have a fairly big research team. We have over 20 full-time researchers in our team, which is very ably led by Sarah Vreugde, who is going to present after me. And really our whole focus for this team is translational health research. And we do pride ourselves on the fact that our research has already been reached the market, and you know, we do have FDA approval for some of our products, and they are being sold currently in places like the USA, New Zealand, and we are within a week or two's approval for Europe as well for that. Main focus of our research has been on chronic sinusitis and the etiology of chronic sinusitis and treating recalcitrant infections in that area. But we also have a significant research stream on wound healing, and we also do innovate surgical techniques. So I'm not going to talk about the surgical technique aspect of it. I'm going to concentrate on the wound healing side, and Sarah is going to present on our research on chronic sinusitis. We excitingly have a new node, which is one based around head and neck cancer, with Kevin and Kenny joining us with Kat to look at how the microbiome influences the inflammatory processes around the cancer, and what influences that has on the cancer itself. So that's an exciting new area for us as well. And Sarah's going to really concentrate on this, so I'm not going to talk much about chronic sinusitis, but that's really where our major grant funding has come from in the recent years. So I really wanted to talk about wound healing after surgery, and specifically in the sinuses. The sinuses are an environment where there's a lot of inflammation, and where there's a lot of inflammation, you tend to get poor wound healing. You get a lot of fibrosis and adhesion formation when you have inflammation. And so we've concentrated in the sinuses, but we have branched out to the spine and the abdomen. And we also have a wound stream looking at hemostasis and looking at particularly effective hemostatic products, which can control things like carotid artery injury and major vascular injuries as well. So, you know, that's a different stream, which I really I'm not going to talk about today. So the Chitogel is the product that we brought to market. We had FDA approval now for 2 years in the US. It's been sold by a distributor contract with Medtronic, and it's also on sale in New Zealand at the moment. And we have got 20% of the market share in New Zealand already after 12 months. The CE mark is imminent and is currently going through the TGA process, and we expect TGA approval by July of this year. This is just a video to show you the Chitogel in a patient, just to show you the differences that we would see in the same patient who's received Chitogel on one side only. So this patient, you know, all of the inflammatory factors are the same on both sides, as you can see on the CT scan. The extent of inflammation on the CT scan is extensive. The surgery performed by the same surgeon and is exactly the same surgery on both sides. So the patient is actually randomized at the end of the surgical procedure as to which side will receive the Chitogel and which side won't. And we can see there's a consistency in terms of surgery on that's the left side. And we're trying to get hemostasis because the product Chitogel is also quite hemostatic. If we look at the right side surgery, again, lots of polyps and inflammation within the sinuses, significant disease within the sinuses, which we then take out. But the surgery we can see is exactly the same in terms of the end product before randomization. At this point, we measure the sinus ostia to get an idea of exactly the size, so we can compare left and right healing. You can see there's quite a lot of blood in the surgical field, and then you can evaluate the hemostatic application that Chitogel has, as well as its other properties. So the Chitogel goes in on the right side of the sinuses only, so only the right side, nothing on the left. And we can see immediately the Chitogel goes in, we get hemostasis. And so we get complete cessation of bleeding on that right side. And we can see that by looking down into the nasopharynx that the bleeding stopped completely. Now, if we compare that to the left side, which has had nothing put into it at all, and we have ongoing bleeding and problems on that left side, despite the fact that both sides have been treated and managed exactly the same. And if we look at 2 weeks post-op, the left side, we've got some edema, some swelling, and we've got quite a lot of narrowing of that frontal ostium, which we're looking at right now. And we've got quite a lot of scar tissue formation already forming in the sinuses on that left side. If we compare that to the side that had Chitogel, we can see that there's less edema, less swelling, and certainly less fibrosis around the frontal ostium that we can visualize on that side. And if we compare that again at 6 weeks post-operatively, on the left side, we can see the strong fibrosis present around the frontal ostium and within the ethmoid cavity. And we can compare that to the right side, and we can see that there's very little fibrosis around the frontal ostium. The ostium itself is much widely more patent and healing much improved on that side that received the Chitogel. All other factors exactly the same. So post-operative care, there you can see mucus within that frontal ostium. On the side that received nothing, a lot of scar tissue band formation within the sinuses. And both sides are treated exactly the same in the post-operative period. So all of the systemic medications and washes are equally presented on both sides. And we can compare that to the right side, and we can see a significant difference that we have between the two sides. So if we look at how this pertains to the abdomen and the spine, what we found is that if we added deferoprone to the Chitogel, that we were able to have a significant increased anti-inflammatory property and reduced fibroblast migration. And so we looked at laminectomy after spine surgery, because 36 to 60% of spine surgery are followed by what they call failed back syndrome, which is a problem where they have long-term ongoing pain after surgery. And what we did in our sheet model is we did laminectomies at different levels, and then we looked at the MRIs after putting Chitogel only at one level, and then comparing it to a whole lot of other products. And here we can see the level of fibrosis, and we can see the Chitogel plus deferoprone have a significant decreased amount of fibrosis within that and inflammation. And if you compare that to MediShield, now MediShield is a product that's on sale for use in the spine after spine surgery at the moment. And MediShield, in fact, is very much the same as the control in our research. In abdominal surgery, we know that a large number of abdominal surgeries are performed every year, and adhesion formation is a problem. And so we've standardized our abdominal adhesion model in the rats, and then we've applied the Chitogel and looked at it both with H&E stain and with a Mason's trichome stain to evaluate the fibrosis afterwards. And we can see again that we have a significant reduction in adhesions and fibrosis with the Chitogel and deferoprone after surgery. So that's all I'm going to present, just a short summary of what we're doing in the wound healing space. And I'm happy to take any questions before we hand over to Sarah to look at some of the research we're doing in the pathophysiology of chronic sinus disease.
PJ, this is clearly a very translational project you've been running, and obviously getting FDA approval is an extraordinarily useful testimony to what's going on. How long from when you had this sorted out to when you actually got it approved by the FDA?
Yeah, so it's really interesting, the translational process, and actually we learned a hang of a lot by it. So, you know, the process that we took was to try and keep investors, especially the groups that were looking at investing early and want to really take over your project, trying to keep them out of the system as long as you possibly can. The venture capitalists are the ones that really take over and really try and drive the whole process. So trying to keep the venture capitalists out. So if you're going to do that, or you want to follow that pathway of trying to keep the venture capitalists out, what we really need to do is we need to get grant funding to support the initial projects that we're going to do. And we need to show clinical effectivity, because there's no point in even trying to get FDA approval if you don't show significant clinical effectivity. So we really look at what we call the wow factor. So we've got to have something that had the wow factor. And so we have the wow factor with Chitogel in the sinuses, but we didn't have the wow factor when we use Chitogel on its own in both the spine and the abdomen. So we needed to look at getting the wow factor, and adding the deferriprone to the Chitogel seemed to be able to generate that wow factor for us. And so now when we complete our animal studies in both these areas, the next step would be to look at a clinical study. And then once we have the clinical study, then we need to build a factory. And that's when we need significant investment, because you need to then repeat some of the clinical studies with the product that you produced in the factory, the actual product that's going to go on sale in the market. You can't use a research product for the data that you submit to the FDA. The data that you submit to the FDA have to be supported by the actual product that's going to be taken to market and the whole sterilization manufacturing processes of that product. So you can't have that product going through a different sterilization, packaging, manufacturing process and submit that to the FDA. You have to have your final product that you're going to be. So the expense comes when you show your wow factor, is then generating enough funds to have a factory to build the product that's actually going to go to market. And that's where the significant money comes in at that stage before you go to FDA. And that for us, with Chitogel, when we started, we built the factory probably 5 or 6 years ago.
Well, thank you, PJ. We are a little bit late, so we'll keep moving. Sarah, the pathophysiology of chronic sinusitis, fire away.
So we have a large laboratory focusing on chronic rhinosinusitis. So these are people that are working in our group. So we have Claire, who is the lab manager. We have 4 postdocs that are doing various aspects of our research. And we have 2 research assistants, Karen and Catherine, who is also taking care of our ethics application. And we also have ethics applications, and we also have George, who is doing our bioinformatics analysis. It's just to say that it's a large team supported by many people. Okay. PJ? So chronic rhinosinusitis is defined as a chronic inflammation of the nose and the sinus mucosa, and it's associated with relapsing infections, and it's affecting about 10% of populations. Yeah. And it's a multifactorial disease where multiple factors play a role. And in our laboratory, we are looking at more or less all of these factors to see how they contribute to the pathophysiology of this disease. Yeah. So in order to do that, we have about up to 10 patients per week that undergo endoscopic sinus surgery. And we collect almost everything from those patients, including clinical information, as well as serum, bacteria, bacterial swabs as well as tissue blocks. And we've been doing that for a couple of years now. So now we have a database and a tissue bank that stores all of this information and these resources from more than 1,000 patients. So we look at CRS disease severity scores for these patients, both sinonasal outcome test with the name of SNOT-22, that is a quality of life score basically, as well as radiology scores and endoscopic scores for all of these patients. And we take bacterial swabs, and those bacterial swabs and tissue is taken at the time of endoscopic sinus surgery, so the patient doesn't really realize we are it doesn't feel anything when we take those samples from the patient. With the bacterial swabs, we can then do microbiome analysis, and we've done the largest microbiome analysis published to date, and that was led by our department, by Alkis Saltis from our department, and it included more than 400 patients, and what we saw is that in CRS patients, there is dysbiosis occurring with a reduction in the relative abundance of Corynebacterium and an increase in various pathogens, including Staphylococcus aureus. Yeah. And when we then isolate the Staphylococcus and also various species from these patients, next slide, we can then establish the biofilms from those bacteria from those patients, and where we can then measure the metabolic activity and the biomass, for example. So we can measure various properties of the biofilms that come from these patients. Yeah. And we also have an in vivo model, so a C. elegans model, where we can establish biofilms and use various compounds to inhibit the growth of these biofilms within those worms. We also have advanced cell culture techniques that we use using primary cells, so primary nasal epithelial cells that we get from the brushes, but also fibroblasts and osteoblasts that we get from tissue samples from those patients. Yeah. And next as well, PJ. So we can we then grow these primary nasal epithelial cells at air-liquid interface, which is growing a pseudostratified epithelium. That is forming a mucosal barrier with the tight junctions and cilia that you can see here. Once we establish these cell cultures, we can then apply various samples or mucus samples in this case to these cells and see how that affects the barrier that we can then measure using transepithelial electrical resistance, as well as immunofluorescence of those cells to look at the tight junctions. We also harvest the supernatants from these cells, where we can then do cytotoxicity assays or ELISA, for example. We also established the technique of growing nasal organoids, and that has been established last year by Manas Ramezanpour, who is a postdoc in our group. And as you can see here, these nasal organoids, they have beating cilia, and we can freeze and defreeze them and do various high throughput analysis using these organoids. Next. The tissue that we get from patients, we paraffin embedded and can do then histopathology, and we can also use fresh tissue samples to do flow cytometry. So this is just a normal paraffin and H&E staining, but we can also do more advanced immunohistochemistry, like in this very beautiful image, and we do that in collaboration with the Peter Mac Institute in Melbourne. Yeah. Flow cytometry, we do that on fresh tissue samples that we dissociate in single cell suspensions, and then we can really characterize the immune cells that are present in those patients. Yeah. So the beauty comes when we put all the data together. For example, we now have clinical information from a patient as well as serum, where we can define the antibody response. We have bacterial swabs from the same patient, where we can then establish the biofilms, for example, from an infecting Staph aureus, and we can determine all the properties of these biofilms along with the genomic content of these biofilms. And we can relate how the biomass and the metabolic activity, for example, that we measure in those biofilms, how that is different in relation to the differences that we see in terms of immune response by results that we have from our flow cytometry from the same patient, and how that then also relates to disease severity. And in order to bring all of these data sets together, to integrate all of these data sets, you really need to have a bioinformatics expertise, and this is where George comes into the picture. And this is where we really see the most interesting findings. Yes. We also focus on finding new treatments for CRS and multi-drug resistant infections. So rhinosinusitis is actually the most frequent diagnosis for which antibiotics are prescribed. And that's a problem because it really contributes to antimicrobial resistance worldwide, because it's a very frequent disease. Bacterial biofilms are actually much less sensitive to antibiotics than planktonic forms. So the antibiotics don't really work to eradicate these biofilms, and we need new treatments to kill those biofilm forms. So we have been working on several treatments. So DevGap is a combination of two compounds that synergistically kill difficult to treat invasive infections. And we've been developing this mainly for non-tuberculous Mycobacterium abscessus infections in cystic fibrosis patients. We've developed protocols and we are able to make silver nanoparticles in a very efficient way. And we are going to use these silver nanoparticles probably this year in a clinical trial. And we have interest from a commercial partner in the United States that is interested to develop these particles together with us. We've also been interested in bacteriophage therapy for a long time. Yeah. And late last year, we have actually established the Adelaide Phage Therapy Center together and supported by All Cells Research. And the aim is to develop a phage bank and phage products targeting therapy refractory infections towards clinical use for patients. And we've been successful in isolating and characterizing various phages targeting Staph aureus, Pseudomonas aeruginosa, and E. coli. So these are just some projects that we are working on. So we have the phage projects, we look at host pathogen interactions. We are focusing very much on finding new treatments for CRS and biofilms, and we have established in vitro and in vivo safety and effectiveness studies that are ongoing. We also work towards optimizing existing treatments for CRS, for example, improving formulations, but also improving delivery methods. We look on we work on the molecular basis of dysbiosis in CRS and other things as well, the role of antibiotics in enhancing bacterial virulence over time and its role in CRS. So these are our main sponsors. We have All Cells Research, the Garnet Path, NHMRC, and the Hospital Research Foundation that are helping us with financing all of our research activities.
That was really great. I just wondered, the Productivity Commission produced its report last week, and it says lots of things, but it does talk about better networking and better collaboration and better support. It strikes me that you've been, from what you've described to us, sort of rather forced to create your own expertise within your lab rather than necessarily being able to easily network with others who could work with you. Has that been an impediment, and do you think there's an opportunity for you to think about being more collaborative with South Australian groups? I mean, clearly you've got international collaboration, but it does seem that maybe that has been less than you would have liked.
We are collaborating with various people also in South Australia with Flinders University. We have been developing phage projects together, for example, with Clive Prestige Group and Nikki Thomas. We are developing new formulations to improve the existing delivery and for corticosteroids for optimizing these treatments. So we are working together with them on an NHMRC project that we have together. And we are also collaborating within the institute. I mean, we are working at the Basil Hetzel Institute. It's a small institute, and we work together here as well with other groups. I don't think we are not collaborating. I'm also collaborating with people at the faculty, like Keith Sherwin, for example. So no, we are using and with the engineering faculty, we have a big collaboration with the engineering faculty as well, actually. So no, I think we are taking every opportunity to find collaborations locally, but also internationally, definitely. It's really a niche environment and it's a niche area of research, and not so many groups in the world are doing what we are doing. So the collaborations are not always obvious to find, but we do collaborate as much as we can.
Look, Sarah, thank you very much. We'll wrap up. Look, this is the first of these seminars for this year. They're going to continue on a weekly basis. We've got an excellent program. It's already been pre-circulated. New speakers will be back again next Tuesday at 4:30. So Sarah and PJ, thank you very much. It is an interesting area. It's come from nothing and is now an absolute powerhouse. And I think we're all certainly at the QEH very proud of what you've achieved. Thank you very much, and we'll see you next week.
Thank you, Guy.
Right, bye.